Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Sridhar Chaganti from UK, and he's going to lecture us on an update on DLBCL from EHA and Lugano. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Unipath, Lucian Life Sciences, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Roche, Unipath, Lucian, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Anshul Gupta, hematologist from Lucknow, our guest speaker for the day, Dr. Sridhar from UK, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 12th of July 2025, from 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time USA, we have Dr. Cindy Nunat from New York speaking to us on ITP and update from ISTH 2025. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will stop for a while for you to have a look on all our discussions for the day. So these are our discussions for the day. Now it's time to introduce our guest speaker for the day. We have Dr. Sridhar Chaganti from UK. Just to introduce Dr. Sridhar Chaganti, he is consultant hemato-oncologist at University Hospital Birmingham, UK, and has an interest in lymphomas, ALL, stem cell transplantation, and immune effector cell therapies, including CAR T-cell therapy. He is a clinical lead for CAR T-cell program and lymphoid diseases. His research interests include aggressive lymphomas and immune therapies, including CAR T-cell therapy. He is a chair of the UK High-Grade Lymphoma Research Study Group, co-chair of the UK National CAR T Panel, and ex-chair of the BSH Lymphoma SIG. He is an author as well as co-author on several scientific publications and BSH guidelines. He serves as a clinical expert for NICE technology appraisals and NICE scientific advice committees. He is a chief investigator as well as principal investigator for several clinical trials. Today he is with us and is going to lecture us on an update on DLBCL from EHA at Lugano. But before he does that, let me introduce our chief guest and the special guest for the day. We have with us no other than Dr. Anshul Gupta from Lucknow. Let me introduce Dr. Anshul Gupta to all of you. He presently works as a director, Department of Hemato-Oncology and Bone Marrow Transplant at Medanta Hospital, Lucknow. He formerly worked as an additional professor, Department of Hematology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Uttar Pradesh from the year 2013 to 2022. He holds the credit for establishing the first dedicated pediatric bone marrow transplant center at Navalokka Hospital, Colombo, Sri Lanka in the year 2012 to 2013. He also graduated from Jawaharlal Nehru Medical College, Aligarh Muslim University, Aligarh, Uttar Pradesh in 2004, followed by then he underwent postgraduate training MD in pediatrics with gold medal from Jawaharlal Nehru Medical College, Aligarh Muslim University, Aligarh in 2007. And then he underwent 3 years FNB training in pediatric hemato-oncology from Rajiv Gandhi Cancer Center and Research Institute, New Delhi. He is also conferred by gold medal by National Board of Examination in the Fellowship Exit exam. He worked as fellow training for 2 years in the Department of Hemato-Oncology and Bone Marrow Transplant at Rajiv Gandhi Cancer Institute, New Delhi. He underwent observership in pediatric bone marrow transplant program at St. Jude's Children's Hospital, Memphis, USA. His special interest is in pediatric leukemias, hemoglobinopathies, bleeding disorders, and stem cell transplant. He has been the principal investigator for several extramural research projects on thalassemia and hemophilias and holds the credit for establishing Center for Excellence for Hemoglobinopathies and Bleeding Disorders at Department of Hematology, SGPGI, Lucknow. He has more than 80 publications in several national and international journals. Today he is with us, and I welcome him to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Anshul Gupta.
Good afternoon, everyone. And And at the outset, I would like to thank Dr. Amit and Maharashtra Mumbai Hematology Group for giving me this opportunity to chair the session on advances in the DLBCL management. As we all know, that diffuse large B-cell lymphoma is one of the most heterogeneous disease for a hematologist to practice, because you see the patients with a very indolent form of lymphomas many times which have a very good prognosis, and sometimes we see patients with a very aggressive disease in which we are not even able to achieve a remission. So in this current era now, as more and more bispecific antibodies and CAR T cell therapy coming into the foreplay in the management of DLBCL, I feel that it's a ever advancing field. And plus, the cell of origin has also made a lot of difference in the management, because after this theory came of cell of origin, and the management plan, the risk stratification, everything changed in the management of DLBCL. So, without any further ado, I would like to invite Dr. Sridhar, who is a senior hemato-oncologist from Birmingham, to enrichen us with the latest updates in DLBCL from EHA and Lugano. Welcome, Dr. Sridhar, and you can start your session now.
Please, Dr. Sridhar, the screen is yours. Please go ahead.
Thank you, Amit and Anshul, for the very kind introduction and for introducing the background for my talk. I'll just start by sharing my slides. I'm just looking outside the window because it's been raining heavily. And for those of you who are following the test match, it is day 5 test match. I'm sitting in Birmingham, in Edgbaston, I live. The cricket stadium is just 20-minute walk from home. So the match is due to start in 4 hours. So, well, I think the initial bit will be washed out, at least. I guess many of your participants will be following the match. Am I sharing now?
India is always
No.
lovers.
Sorry?
India
yeah.
is lovers.
And India is in a good place in this match.
Match, nobody leaves.
Sorry, I think I was sharing the wrong window. I'm trying to share the right window. Maybe the best option is to share this way. Let's try this. Yeah, you can see it.
Yes, sir. You can put it in the full screen mode.
Yeah.
Perfect. Please go ahead, sir.
So thank you, everyone. Thank you for joining today. And I'll just be updating from, EHA and Lugano, essentially. It's mainly updates from diffuse large B-cell lymphoma. There's a lot happening in the field, as you know, DLBCL is quite a broad kind of entity. So I will only be presenting selected abstracts and my thoughts on what this means for today and going forward. These are kind of selected for more of practice changing or practice informing abstracts, but there is kind of a bias towards abstracts which come from our own group in the UK. So this is going to be the outline of my talk. We'll look at what's happening in the first line DLBCL setting, emerging role of ctDNA, MRD assessment in the first line setting again, relapsed refractory DLBCL in transplant and CAR T eligible patients, and the same in transplant ineligible patients. And lastly, I have a few slides on CNS lymphoma. So I think I have 45 minutes to do my talk. Is that right?
Yes, sir. You can take your own time.
Yeah. So this was an interesting abstract presented at Lugano from Margaret Shipp's group from Harvard, looking at POLA-RCHP in the so-called DLB class, defined molecular subsets of newly diagnosed diffuse large B-cell lymphoma. And this is analysis from the POLARIX trial. Now, my understanding is polatuzumab is available in India. Somebody did contact me about adding polatuzumab to R-CHOP from India. So I'm assuming you guys have been using, at least in some patients. In the UK, it is NICE approved for patients with IPI 2 to 5 as per the POLARIX trial. Now, before I come to this slide, just to give a brief background for those of you who are not DLBCL kind of specialists. POLARIX trial was randomized trial, phase 3 randomized trial, 800 plus patients in the trial, which compared, sorry, that's not related to this slide, by the way, that's just a background, which compared POLA RCHP versus R-CHOP chemotherapy. And it showed a 6% PFS benefit for addition of polatuzumab to RCHP chemotherapy without vincristine. And that benefit has been sustained at a 5-year kind of follow-up, which was presented at ASH last year. So there is a 6% PFS benefit for patients with DLBCL IPI 2 to 5 was the inclusion criteria. And there was no OS benefit either at the 2-year initial analysis or at the 5-year update. So there is no overall survival benefit in POLARIX trial. And there have been subgroup analysis looking at different subgroups in the within the trial. And one of the most interesting, most debated and discussed subgroup has been the ABC versus GCB subtypes as defined by gene expression profiling. And the benefit of adding polatuzumab to RCHP seems to be restricted exclusively to the ABC subtype with no benefit of adding polatuzumab to the GCB subtype. And this has caused or generated a lot of discussion and debate even in our own practice. Even in my own hospital, there is a debate that happens about whether you should be adding polatuzumab to a GCB DLBCL, for example. So this analysis is from Margaret Ship's group. As I said, this is on POLARIX trial, but they have previously described genetic clusters. This paper is going back to 2018. So we know that the gene expression defined ABC and DLBCLs, ABC DLBCLs are not a homogeneous entity. They are a heterogeneous entity with different outcomes in different patient groups. And we understand a bit more about it now based upon this kind of genetic clustering of DLBCL. So this is a genetic classification of DLBCL proposed by Margaret Ship's group. They used extensive genetic analysis on DLBCL tumors at that time, which included identifying mutations specific to lymphomas, copy number alterations, structural variants, and they were able to group DLBCLs, newly diagnosed DLBCLs, into 5 different so-called genetic clusters. Of special relevance to this talk today is the clustering of the ABC DLBCL. So if you look at, you can see my cursor, isn't it, when I move it? Yeah. Can you? Or is it better if I make it into a bit of a...
We can see your cluster, sir.
I'm just trying to see if I can give it a bit of a color and make it a bit better. Can I? No, it doesn't work. Maybe I'm not doing the right thing.
Your cursor is not shown yet. Okay.
Yeah, okay. Let's just keep with the cursor, yeah? So that's the group I'm talking about. So cluster 1 and cluster 5 DLBCLs, they are kind of enriched for ABC type DLBCL. So the gene expression defined ABC DLBCLs cluster into mainly cluster 1 and cluster 5. And those are the outcomes for these ABC DLBCLs. So cluster 1 DLBCLs have a much better outcome than cluster 5 DLBCLs. Cluster 1 seems to be enriched for the so-called low risk ABC DLBCL, whereas cluster 5 seems to be enriched for the so-called higher risk DLBCLs, which often have activating MYD88 and CD79B mutations. So this is the group of interest for this particular analysis as we go forward. So in this particular abstract, they looked at 407 patients enrolled in the POLARIX trial. So roughly half of all patients enrolled in POLARIX trial. And they used this new platform, the DLB class platform that they have defined again recently, published just this year. So the DLB class is just a genetic tool that can be applied to essentially identify the same genetic clusters they described before. So it is a platform that can be used by other places now. And it is something which has worked very nicely in this analysis. All patients, all 407 patients were assigned a genetic cluster. So it was able to categorize 100% of patients that they looked at. And as you can see, the genetic cluster 5 about nearly a quarter of all patients in the POLARIX trial were assigned the genetic cluster 5. And these were the outcomes. So this is PFS of patients in these clusters in the POLARIX trial. And as you can see, the benefit of adding polatuzumab to RCHP chemotherapy was exclusively in cluster 5. There was no benefit of adding polatuzumab to clusters 1 to 4. In cluster 5, the PFS was 70% for adding polatuzumab. That's 5-year PFS we are talking of, compared to 42% for patients who did not receive polatuzumab. So, I mean, these are the author's conclusions. So one is the DLB class platform performed very well in this study and was able to identify or classify all patients into the different genetic clusters. And the cluster 5 was the only one where patients derived benefit. So how do we take this forward in the real world? That's a bit more difficult because none of us routinely either do gene expression profiling to categorize either ABC or DLB or GCB DLBCLs, and we do not routinely do cluster 5 or genetic clustering by mutation analysis. But this is something which may be coming because it's easier these days to do this analysis than we were able to do in the past. Sometimes it is cheaper to do a whole genome analysis rather than spending money on doing different fish for different rearrangements, for example. So this is not here and now, but this is something maybe for the future. But at this point in time, this will be an analysis which it will inform clinical trials at least, and how we look at clinical trial data. The other abstract of interest, which is of relevance, for practical relevance to our practice today, is the use of the dose-adjusted EPO-CAR. And this is in the context of the FISH-defined double-hit lymphoma. So these are lymphomas with MYC and BCL2 rearrangements. This is from the British Columbia Cancer Group. So they did a era-wise comparison of patients treated in Vancouver and in the British Columbia region. So this is looking at patients treated previously in a historic era, which they call the RCHOP era. That was in 2005 to 2010. And then they looked at patients treated in a more recent era, 2015 to 2020. Patients in the second era were treated more often with DAI-EPO-CAR because the BCCA group, they published a guideline which recommended use of DAI-EPO-CAR for double-hit lymphomas in 2015, and looks like within their region, the guidelines are generally followed more closely. So it was also important, I mean, they kind of segregated the two groups also on the basis of application of FISH. So one of the problems of any double hit lymphoma study, retrospective study that you look at, is the FISH testing is done selectively. So if you only test patients who you think are high risk, then you are essentially, introducing a selection bias even for the FISH testing. So they tried to apply or choose their eras based upon unselected FISH testing. So between 2005 to 2010, they had FISH done on majority of patients on a research kind of protocol. And in 2015 to 2020, again, a lot of DLBCLs, we are talking of a lot of DLBCLs were FIShed following the application of the guideline. So they looked at something like over nearly 2,000 patients with DLBCL across the two eras. The inclusion criteria was patients with a DLBCL morphology and age less than 75 age. They restricted basically because they were looking at EPO-CAR type chemotherapy. So patients over the age of 75 generally not given EPO-CAR chemotherapy. So those were their inclusion criteria: DLBCL morphology and age less than 75. So if you look at the EPO-CAR era, that's 2015 to 2020, they started with 1,000 patients they identified with DLBCL morphology. 700 had FISH done, and of the evaluable patients, 66 had FISH identified double hit rearrangements. So that was their kind of population, 66 patients in the DAI-EPO-CAR era. And in the historic era, they started with 760 patients, 600 had FISH done, and 38 were double hit rearrangements. So remember, this is a comparison of two eras. Uh, 66 patients in the DA-EPOCAR era and 38 in the R-CHOP era. But in terms of treatment application, that was not kind of all uniform. So in the so-called DA-EPOCAR era, where they have 66 patients now, only 47 actually received DA-EPOCAR. So 15 patients received R-CHOP in this era, probably because patients were deemed not fit enough to receive DA-EPOCAR or performance status or whatever it might be. And a few patients were received other chemotherapies, including palliative regimens. The same in the historic era. The historic era was slightly better. 32 of 38 actually received R-CHOP, but a few others received other regimens. So this is not comparison of DA-EPOCAR and R-CHOP, but comparison of eras enriched for those treatment regimens. And these were the outcomes. So this is freedom from progression on the left side and overall survival on the right side, which show a significant improvement or benefit for application of DA-EPOCAR chemotherapy to R-CHOP chemotherapy, or significant improvement between the two eras, I should say. That's probably the more correct way of saying it. So patients treated in the more recent era had a much better freedom from progression compared to patients treated in the historic era. So they also went on to look at the dark zone signature, which is again, say, based upon gene expression profiling. It's a little bit like it classifying into ABC and DLBCL. So the dark zone signature DLBCLs, or high-grade B-cell lymphomas, they are enriched for patients with double hit lymphomas. And generally, typically, it will identify something like maybe around 10% of all DLBCLs, or 10 to 15% of all DLBCLs, compared to the double hit itself, which is roughly around 5 to 6% of all DLBCLs. So the dark zone signature, it's also called molecular high grade in the UK. This signature, again, when it was applied to these patients, 45 of the 66 patients in the DA-EPOCAR era, they were able to do the molecular profiling, and roughly around 80% of patients across both eras, where they were able to do the molecular profiling, roughly around 80% of all the FISH identified double hit lymphomas were positive for the dark zone signature, if you like. And if you look at the overall survival panel on the slide, you can see that the dark zone signature, where it was present, was really driving the adverse outcome in these patients. So those patients who were just FISH positive but dark zone signature negative, their outcomes in both eras was better than patients who had the molecular signature of dark zone lymphomas. The outcomes were better for in the DA-EPOCAR era compared to the R-CHOP era for both, whether patients had dark zone signature or not. Outcomes were better across the two eras. So again, what do we draw as a conclusion from this kind of retrospective analysis? I don't fully know what to say of this, really. This to me is, if you're a DA-EPOCAR believer, as some of my colleagues are, then this kind of study sets, or provides further, you could say, evidence to support your practice. If you're a non-believer in DA-EPOCAR, then you will say that this is historic, retrospective, plenty of selection bias probably, and doesn't really change what you want to do. So this is more of a provocative data, practice is informing data, if that is your practice. But I don't see this data as being enough to change practice if you're delivering R-CHOP to your patients, or Pola RCHP, for example, because Pola RCHP, addition of polatuzumab, I did say on the previous slide, showed benefit for ABC and not to GCP. But adding polatuzumab also showed benefit for the patients with the molecularly defined dark zone signature. So again, we also learned that IPI is probably important, as opposed to just identifying the double hit kind of rearrangement by FISH. So when you're looking at double hit, it's not just looking at double hit, you're also looking at the stage, whether it's early stage or advanced stage, and also looking at IPI. I only changed my practice, or I used to change my practice for IPI 3 to 5. And these days, with adding polatuzumab, I kind of moved increasingly away from using diprocars and arcodoxins, at least in my practice. So this is a study which I guess adds a little bit more evidence to using the more intensive regimens for double hit lymphoma, but comes with lots of caveats. Very interesting was looking at the role of ctDNA, MRD, and there were a couple of really interesting presentations. One coming from our own group in the UK. So this was done by Dan Hodgson, who's a brilliant hematology. He's a scientist, but he's a hematology consultant. Very bright chap, works in Cambridge. And he has led on a study which was called a DIRECT, which was looking at ctDNA in newly diagnosed diffuse large B-cell lymphoma. So he recruited 198 patients into the DIRECT study, and these are all newly diagnosed diffuse large B-cell lymphomas. And the ctDNA assay that he uses is an in-house assay developed in Cambridge in his lab, which is lymphoma customized capture-based ctDNA assay. And the analytical pipeline which includes genotyping as well as phased variant MRD capability. So some of you may have heard of the phased variant kind of MRD, which is promoted heavily by the Stanford group. It's called the Foresight assay now. It's a commercialized assay now. So Dan's assay is very similar to that assay, except this is generated from an academic lab and is still within an academic lab. So he had a median follow-up of just over 2 years on all the patients recruited. So the DIRECT study had 3 objectives. One was looking at the role of ctDNA in pre-treatment risk prediction of DLBCLs. The second objective was looking at the role of ctDNA in baseline tumor genotyping. So can you just get rid of tissue biopsy and just do it entirely on a blood sample, was the second objective. And the third objective, which is what this presentation relates to, is looking at the role of this phased variant MRD on the end of treatment samples. So this was the consort diagram. So he had 198 patients, of which 188 were eligible for the study. And that's he calls cohort 1. And then cohort 2 essentially is 165 of the 188 patients who were treated with anthracycline containing chemotherapy. So cohort 2 is, you could say, R-CHOP or R-CHOP like chemotherapy patients. And end of treatment, 23% of patients were positive on MRD using his assay. So 3/4 negative, a quarter were positive. And that's the freedom from progression of these patients. So on the left panel, that's just simply looking at patients who were MRD positive and MRD negative at the end of treatment. So if you were MRD positive, which the 23% of patients were in the trial, their 2-year freedom from progression was 39%. There was a very high negative predictive value for MRD negative patients. 95% of them were free from progression at 2 years if they were MRD negative. But Dan also went on to look at, the difference between patients based upon their end of treatment PET scan. So these are patients who had a positive PET scan at the end of treatment. So they were in a PR. So remember, these are not stable disease or PD patients. Just looking at patients who are in a PR, 25 of his 180 patients were in a PR. So roughly around, maybe 15% or so of patients who were in a PR. Again, roughly half of them were MRD positive and half of them were MRD negative based upon his assay. And if you were in a PR but MRD positive, your freedom from progression was running around 36% at 2 years. And if you were in a PR and MRD negative, your freedom from progression is still very good. The assay is still performing very good at 92%. Patients remain progression free. So again, sometimes there is this habit of changing treatment for patients who are on a PET negative or a PET positive PR. I usually don't. I usually try to do a biopsy before I make any treatment change. But if you are trying to initiate new therapy to a patient just because they are in a PR or a PET scan, remember there is a 50% chance that they may actually not have any disease. You may just be picking up a PET signal as opposed to real disease persistence. PET negative CR patients. So this is analysis on PET. Majority of patients, 120 patients were in a PET negative CR at the end of treatment, and for them again, if they were MRD negative, freedom from progression at 2 years was 96%. If they were MRD positive, freedom from progression was 62%. So the positive predictive value of the assay is not that great. Even in PET positive PR patients, 36% still remain uh, uh, free from progression. So you could say there is a 70% risk of progression maybe, but 30% will still not progress even if they're MRD positive and PET positive. So this is applying the same kind of data to cohort 2. So this is applying to the 165 patients who received anthracycline-based chemotherapy. The results are essentially identical for all patients, for PET positive PR patients and PET negative CR patients, with little differences. So cohort 1 and cohort 2 almost identical, you could say. And this is looking at PFS. Now, the last two slides were looking at freedom from progression, and this is looking at progression-free survival applied to the cohort 2, 165 patients. And essentially, it's the same story, really. If you are MRD positive at the end of your R-CHOP-like chemotherapy, then your PFS is around 36% at 2 years. And if you're in a PET positive PR and MRD positive, it's around 40%. And if you're CMR and MRD positive, around 50% PFS. So remember, if you're in a PET negative CR and MRD positive, you still have a 50% chance of remaining progression free. So the way I see DANS assay is really, really good with a high negative predictive value. There was a lot of discussion about how sensitive your assay has to be, because the next presentation I'm going to show is based upon the Foresight assay from the Stanford group. And they claim a 1 part per million kind of sensitivity on their assay, as in you can identify one tumor copy in the background of 1 million cells. Dan's assay probably comes to around 500,000, and it's interesting to see that he's got a very good negative predictive value, a slightly lower positive predictive value. This was the other assay. This is from the Ash Alizade's group in Stanford using their assay, but the assay was applied to patients from Belgium and Netherlands. So this is a study from the Howard group. Martin presented this, so Martin Chamilou from the Howard group presented the abstract at Lugano. So they applied the Stanford assay to patients treated in the real world in Netherlands and Belgium. In the end, they had 160 patients who were tested with the assay. These are all, we're talking of end of treatment MRD here. And again, it's almost the same as what Dan showed. 21% of patients were positive for MRD at the end of treatment. So around 80% were MRD negative. What Martin also showed is your baseline characteristics do influence the risk of being MRD positive. So if you're only stage 1 or 2 disease at baseline, which a minority of patients are, then you have very low risk of being MRD positive. Whereas if you're stage 3 to 4, then around 25% were MRD positive. Similarly, IPIs also seem to influence. If you're only IPI 0 to 1, the risk of being MRD positive was very low. And it's mainly IPI 3 to 5 patients who were MRD positive at the end of treatment. And on this assay, as I was just saying, a couple of slides ago, on this particular assay, the positive predictive value was actually much better. So this is PFS now on the left slide. So for the 20% of patients who were MRD positive at end of treatment, their PFS, this is 3-year PFS we are talking of, is only 15%. So a majority of patients will progress. And if you are MRD positive, they have a slightly lower negative predictive value, so 85% PFS compared to 95% that Dan's assay has. Overall survival, shown on the right side, again, there is a significant impact on overall survival if you are MRD positive at the end of treatment. So Martin also showed data based upon IPI at baseline and end of treatment PET scan. IPI at baseline in this patient group. Sorry for that noise, that's the rain here. IPI between was not really that discriminatory, but end of treatment PET scan is. But if you're an end of treatment PET positive, which roughly around 20% of patients in this study were, as in PET positive PMR, these patients are. So if you're end of treatment PET positive, your PFS is still running around 40 to 50%. So again, positive predictive value is not that great. And Martin went on to say that the ctDNA MRD analysis probably is the most predictive of the risk of progression of these three parameters that she compared. Now, this is looking at the same assay in patients who were not in a CMR. So, as I said, roughly around 20% or around 40 of the 160 patients were not in a CMR on the end of treatment PET scan. Roughly half of them are MRD positive, half of them are MRD negative. And if you are MRD positive and also PET positive, then your PFS at 3 years was only 4%. So almost everybody is progressing. But if you are MRD positive and PET positive, then your 3-year PFS is 64%. So combining PET and MRD does, give you a bit more information than just looking at each of them independently. And this is in patients who are in a complete remission now. So these are patients who we would have historically considered to be cured or at a very good chance of being cured. But clearly we can look at the risk of progression, even in these patients who are on a PET negative CMR. If they are MRD positive, then the 3-year PFS is only 36%. Again, this is very similar to what Dan showed, except that if they were PET negative in Dan's, I think their PFS was running around 50%. So again, this assay does seem to have a better positive predictive value, but a lower negative predictive value. Maybe I can just add that, in this particular context, is there something that you can do to these patients, based upon this information? Would you act upon some of these patients? I guess if you go back to the previous slide, patients who are both PET positive and MRD positive, these patients are relapsing rapidly. And, this is by 6 months, the majority of them have relapsed. So there is maybe not that much time to actually do much to these patients. But by the time you come to something like this, where you have patients who will be in maybe remission for a few months. You have a few months to act, and maybe there is a scope to intervene to reduce the risk of progression in these patients. And in this context, we are in designing a trial for CAR T cell therapy to these patients who are in a PET negative remission and MRD positive, to see if we can reduce the risk of disease progression in that group of patients. So looking at the role of what's happening in transplant and CAR T eligible patients in relapsed refractory disease. So this is abstract presented by Raul Cordoba from Spain. This is data from the EPCOR NHL2 trial. For those of you who know the EPCOR trials, there are multiple arms in these trials. EPCOR NHL2 has different combinations tested out with epcoritamab. But to give you the background context to this, we know that patients with relapsed refractory diffuse large B-cell lymphoma, even in the transplant eligible patients, the outcomes have not been brilliant. Historically, treatment included giving them second-line chemotherapy, RGDP or RIs, and if they were responding, they would have received an autologous stem cell transplant. Using that strategy, the cure rates have been less than 20% or even 15% usually. So second-line CAR T cell therapy is now established as standard of care in some parts of the world at least. And with second-line axi-cell or lyso-cell, the outcomes are around 40% PFS at 2 years. So you're roughly curing around 40% of patients with CAR T cell therapy. So majority are still not cured even by applying CAR T cell therapy. So even though CAR T cell therapy represents a advance over historic chemotherapy and autologous stem cell transplant, there are still a lot of patients who do not benefit from it. So this was looking at adding epcoritamab to chemotherapy to see their outcomes. Previously, we have seen data from adding RDHAX chemotherapy, epcoritamab to RDHAX chemotherapy with high response rates, high transplant realization, and very good PFS at 2 years. So this is adding it to RI's chemotherapy. So these patients who are transplant eligible, relapsed refractory, DLBCL, at least one prior line of therapy, ECOG performance status 0 to 2, and they needed to have adequate organ function to be eligible for a transplant. RIs was delivered in standard 3-weekly regimen for 3 cycles. Epcoritamab delivered in the standard weekly regimen for the first 3 months, and then fortnightly for the next 6 months, and then it becomes once every 4 weeks. And in the end, they had 31 patients. It's still a small study at the moment. It's phase 1/2 type study. Majority of patients had only one prior line of therapy. Around half of all patients were primary refractory, and 2/3 of patients had relapsed or progressed within 12 months of their first line treatment. So that will be like the Zuma 7 or transform patient populations. And those were the responses. Overall response rates were extremely good. So if you look at all patients, nearly 90% overall response rate. If you compare it with RIs, for example, on its own, you're expecting response rates of 50% or at least at 60% kind of thing. So this is really impressive that you're getting close to 90% overall response rates. And even if you look at patients who are progressing within 12 months, response rates are pretty good. Complete response rates, around 2/3 of all patients achieving a complete response. Again, so that is impressive for the regimen. So 20 of the 31 patients went on to have a autologous stem cell transplant. So roughly 2/3 of all patients went on to have a autologous stem cell transplant. 14 of the patients were in a CR prior to the transplant, and of the 6 patients who were in a PR, 5 converted from a PR to CR at the time of their transplant. And the 6-month PFS, so it's still a small follow-up. It's a short follow-up. It's only about 8 months of follow-up on the trial, but 74% of patients remain progression-free at the 6-month follow-up. So very interesting data. It's almost asking to challenge second-line CAR T-cell therapy with this kind of data, because we know that with all the hype about CAR T-cell therapy, at the end of the day, it is only applicable to a minority of patients. It's not available in large parts of the world anyway, and even when it is available, to get a patient to CAR T-cell therapy, it takes time, and depending upon insurance reimbursements. In the UK, we are fortunate it's socially funded healthcare, so most patients will be eligible if they meet the criteria. But in many other parts of the world, you need insurance reimbursement, payment, then there is time that it takes to bridge a patient to CAR T-cell therapy. So it's not a treatment which is routinely available for a number of patients. So if you are able to start with a off-the-shelf treatment like this one, it will be an attractive option. But clearly, there is a long way to go for this treatment before it can be considered as equal or better than CAR T-cell therapy. So the safety profile, which is largely as you would expect for adding epcoritamab to chemotherapy, most of it is driven by chemotherapy itself. And these were the conclusions. I don't need to go through these. I think I've already said what I needed to say on this. And then we presented data from our UK group on use of second-line CAR T-cell therapy. So this was analysis led by Andrea Kunnel, who works at King's Hospital, and myself. We co-chaired the National CAR T panel, along with Graham Collins, who works in Oxford. And this was analysis on patients treated with axi-cel in the second-line setting in the UK. So we had also presented, our outcomes, overall outcomes, which are very comparable to the Zuma 7 population. We have about 300 patients infused in the second-line setting, and our outcomes are largely comparable. So that was a poster at Lugano, but this was an oral abstract, because this is interesting stuff. This is looking at prediction of outcome based upon early PET response in this patient group. So this is our cohort. We started with something like 350 patients who were approved by the panel for CAR T-cell therapy, 300 infused. So we lose about 50 patients between approval to infusion, largely because of disease progression and patients becoming unfit for treatment. And we have PET data on 243 patients. 243 patients had PET analysis at 1 month and were in a remission, either a CR. 146 patients were in a CR with dual score 1 to 3, 72 patients in a dual 4 PR, and 25 patients in a dual 5 PR. So we restricted this analysis to patients who were either in a CR or a PR. So 240 of 300 patients were in remission. Either a complete remission or partial remission. So that is our analysis group. And we show that at 1 month PET scan, using your 1 month PET scan, you can predict the risk of PFS at 12 months. So if you're in a CMR, so that's your PFS at 12 months is running at 70%. And if you're in dual 4 PR, your PFS at 12 months is roughly 50%. And if you're in a dual 5 PR, then your PFS at 12 months is roughly 25%. So very, very, very nice segregation of the three curves just based upon PET scan at 1 month. And this is overall survival, which is also affected significantly by your response at 1 month, especially if you're a dual 5 PR. And this is looking at multivariate analysis. So we looked at a variety of factors as shown on the slide, but essentially only two were significant in our analysis. That was the PET response at 1 month and LDH of more than 2 times upper limit of normal at the time of lymphodepleting chemotherapy. This is the time to progression based upon PET scan, roughly translating into at 6 months. If you look at based upon whether you're in a CMR, only 12% risk of progression. If you're in a dual 4 PR, around 40% risk of progression, and around 70% risk of progression if you're in a dual 5 PR. So you could say that if you're a dual 5 PR, then maybe you should start thinking about what next for these patients already, because they're at a high risk of progression by 6 months. If you're a dual 4 PR, then you don't really know what to do, because 40% risk of progression is not enough for you to do anything about it. So what we did is we looked at combining the LDH and the PET at 1 month. And when you do that, then you start identifying that these are patients with, that's your dual 5 PR, the dotted line. But this dotted blue line is patients with dual 4 PR plus a elevated LDH at lymphodepleting chemo. So they are almost behaving like the dual 5 PR. So putting these two together, maybe we can identify a group of patients where intervention is indicated. But what intervention you would do is unknown. So again, that will be part of clinical trials going forward. We also had some data from the EBMT lymphoma working party looking at autograft versus CAR T-cell therapy. So this is for patients who are in a complete remission prior to these treatments. So these are patients who would have received their second-line chemotherapy, RIs or RDDP or whatever, and then went on to have their allocated treatment, whether they were planned for autologous stem cell transplant or CAR T-cell therapy. And this analysis was restricted to patients who achieved a complete remission prior to the planned transplant or CAR T-cell therapy. Historically, CIBMTR presented this analysis. This was led by Mehdi Hamdani and Mazidar Shadman, published in Blood Cancer Journal last year. This is all CIBMTR data. Doing a similar kind of thing. They had something like 350 patients analyzed. 270 had autograft and 75 had CAR T-cell therapy. And they showed that autograft gave a better PFS than CAR T if a patient was already in a complete remission. And they also showed the risk of relapse was much higher with CAR T than with autologous stem cell transplant. So in their retrospective analysis from CIBMTR registry data, it looked like autologous stem cell transplant was doing better than CAR T-cell therapy, but a lot of caveats in the sense they are not really matched populations. Patients who received an autograft typically received in second-line setting. All CAR T in their analysis was third-line CAR T because this was all prior to second-line CAR T being available. So there are caveats. So EBMT registry repeated the analysis, and they have included patients 18 to 80 years of age who received the transplant or CAR T between 2018 and 2022. And overall, They had 2,700 patients, a very large patient group. 2,500 had autologous stem cell transplant, and nearly 190 had CAR T cell therapy. There were important differences, like median age was different between the two groups, as in CAR T cell patients' median age was higher than patients who received autologous stem cell transplant. Similarly, there were other differences. Patients receiving autologous stem cell transplant, or almost about 80% of them received in the second line setting, whereas only a third of CAR T was in second line setting, two-thirds of CAR T was in the third line setting. So treatment lines were different between autograft and CAR T. Also important to note, CAR T different products used, about half were axi-cell and about 40% were TISA-cell, with the rest being made up of a couple of other products there. And that was the kind of summary. OS and PFS was not different between autograft or CAR T. So if you're in a complete remission already, then whether you PFS was nearly significant in favor of autograft over CAR T cell therapy. And this is relapse risk. The relapse risk was lower for autograft than for CAR T, and that P is highly significant. There was no difference in non-relapse mortality. They repeated the analysis using just axi-cell. Remember, because about 40% of patients, or nearly 50% of patients, were non-axi-cell patients. And so the analysis was repeated with just axi-cell, and with axi-cell, there was no difference really between any of these parameters tested. So you could say, if you're in a complete remission prior to your treatment, then it's a reasonable option to offer an autologous stem cell transplant to a patient. And this is, I would say, especially relevant in parts of the world where access to CAR T cell therapy is limited. And if your patient has chemosensitive disease, then an autologous stem cell transplant does equally well and maybe slightly better than CAR T cell therapy would do. And then there's some data on non-transplant eligible patients. Many of you would have heard of the STAR-GLO trial, which compared glofitamab and GEMOX chemotherapy with R-GEMOX chemotherapy. This was a phase 3 randomized trial. This is all published, and this is now EMA approved. It is going through NICE in the UK next week. And if it is approved, it will be available to use. So Jeremy Abramson presented 2-year follow-up, both at EHA and at Lugano. So this is 274 patient study, phase 3 randomized, 2:1 randomization in favor of glofit GEMOX. And patients were considered, or they needed to be considered to be transplant ineligible based upon certain parameters. So this is updated data. Overall survival was the primary endpoint, and 2-year OS, 33% for R-GEMOX versus 54% for glofit GEMOX. So an impressive improvement in the overall survival in this patient group. And this is PFS. For PFS, follow-up was just under 18 months. So the 18-month PFS for R-GEMOX is 23%. Versus 46% for glofit GEMOX. Again, a significant improvement in PFS in this group. They also showed immune recovery. Essentially, the green dots, I think, are the green bars are glofit GEMOX and the blue bars are R-GEMOX, showing that immune recovery generally happened around 18 to 24 months from end of treatment, and there are no big differences between the two groups. There's also data on the so-called SUNMO trial presented by Jason Westin from MD Anderson. So this is adding mosunetuzumab to polatuzumab. So and comparing it with R-GEMOX. So the experimental arm here is chemo-free. And again, very similar study design to the STAR-GLO data, 2:1 randomization. Patients received fixed duration of mosunetuzumab along with polatuzumab, total of 8 cycles of mosunetuzumab, 6 cycles of polatuzumab, and R-GEMOX was kind of standard 8 cycles given on a 2 to 3 weekly basis. And the data is very similar. This is PFS, the median PFS of 11 months for MOS and POLA compared to 3.8 months for R-GEMOX, and 12-month PFS of 48% for MOS and POLA, and just around 18% for R-GEMOX. So data similar to what we see in StarGlow study, but without any chemotherapy here. And the overall response rate of 70% versus 40%, CR rate of 50% versus 25%. So in some ways, the R-GEMOX arm is performing very similarly across both the trials. So again, interesting data. We need to see where this goes, but the overall survival benefit currently is not much. I mean, there is some difference. Mosunpola is doing better than Arpola, but it's not significantly different. So it looks like a PFS benefit, but not OS benefit at this point in time in this trial. CRS was not really a big issue. It was seen in roughly around 25% of patients, mostly low grade, and there was not much ICANS or any ICANS in this study. So lastly, in the last couple of minutes, I'll show you a few slides on CNS lymphoma. I'm only presenting one abstract presented by my friend and colleague Kate Sinaski. She works at UCL London, and she was the UK chief investigator for the Marietta trial, which was led by Andreas Ferreri from the German CNS lymphoma group. This is 7-year follow-up on the Marietta trial, or it was also called the ILSG42 trial. This trial was using a hybrid regimen of matrix and RI chemotherapy, followed by autologous stem cell transplant in responding patients, and this trial was for secondary CNS lymphomas. That is the kind of study flow diagram. So patients with secondary CNS lymphoma were included, and they all received one cycle of R-CHOP to begin with as required, and then they went on to receive matrix along with intrathecal chemotherapy, 2 cycles of matrix chemotherapy, and had a response assessment. And if they had a response, 2 cycles of matrix, then they went on to have further RI chemotherapy for 2 cycles, and responding patients then went on to have a high-dose chemotherapy and autologous stem cell transplant. Primary endpoint was PFS. It was a international study, 24 centers across 4 countries. These were the inclusion criteria: histology confirmed CD20 positive DLBCL, but all patients needed to have CNS involvement. Either at presentation, as in patients presenting with concomitant systemic and CNS lymphoma, or patients who had a previous systemic DLBCL, but then relapsed with CNS involvement, either isolated CNS involvement or relapse concurrently with systemic and CNS involvement. So roughly there are 3 groups in the study. So one is de novo systemic and CNS disease, or relapsed isolated CNS, or relapsed concurrent systemic and CNS. And CNS involvement had to be shown by biopsy or cytology, or by a previous DLBCL biopsy, and imaging appearances being highly typical of CNS relapse. Patients up to 70 years were eligible in the study. And here you can see that, basically a majority of patients had brain parenchymal involvement. I'm not a big fan of this slide in the sense it's the way it is shown. You have to literally look around to see the number of patients who had brain parenchymal involvement. But I think roughly around 20% or so patients had CSF, leptomeningeal disease, but isolated CNS was only isolated leptomeningeal was only a minority. Only 11% had isolated leptomeningeal. So majority of patients will have parenchymal involvement. And this is a very important message from this study. Response after the first 2 cycles of matrix. Remember, they had 2 matrix and then they had RI chemotherapy. So the response to the first 2 cycles of matrix was a very strong predictor of outcome. Patients who had a CR had much better PFS compared to those who had a PR, and those who did not respond to 2 cycles of matrix, you might as well pull out at that stage. And this is looking at outcomes based upon the 3 categories. So the best PFS, left panel is PFS, right panel is OS. So the best PFS, 7-year PFS of 52% was seen in patients with the de novo presentation. So patients who present with new DLBCL involving both systemic and CNS, their outcomes were best, followed by those with isolated CNS relapse, 7-year PFS was 33%. But if you're a combined CNS and systemic relapse, then the 7-year PFS was only 11%, and the majority of these patients died rapidly. The OS curves almost mirror the PFS curves, which tells you that there is not that much you can do to salvage these patients once they progress. The other useful message was patients who received intrathecal therapy in addition to their allocated chemotherapy, their outcomes were better than those who received only systemic chemotherapy without the intrathecals. So those are conclusions by Kate. 7-year PFS for the entire group was roughly around 33%. OS was very much mirroring PFS. 7-year PFS was 64% for transplanted patients. So that's the other important message. Patients who were not transplanted, and 10 patients were not transplanted in this study in the CR or PR for whatever reason, and only one of them remained alive. So 90% of them did not survive. So transplant is important, and those who had a transplant consolidation, nearly 2/3, the PFS for those patients was nearly 65%. And again, just to repeat, treatment-naive patients, newly diagnosed systemic and CNS disease, their outcomes were much better. 7-year PFS of 52%, isolated CNS 7-year PFS of 33%, and combined systemic and CNS, the outcomes are really poor. I've already said that. I think that's the end of the abstracts, really. So I'll stop there, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Sridhar. Wonderful lecture, fantastic, all complete, and that was too good, sir. I think you covered almost everything, and the best part was the CNS lymphoma. That was really great with the validated trial coming up. Thanks a lot, sir. Fantastic. And I now
Thank
request
you.
all our discussants to please put the hand raise sign so that we can start our question answer session with Dr. Sridhar Chakanti.
So whilst your audience warms up, maybe I can ask you something, Amit.
Yeah.
Do you have access to polatuzumab in India?
Yes, we have access. It's
And
everywhere.
everywhere.
Everybody is using
The cost?
Cost is too high yet, but we have some patient assistance programs running up. So
Okay.
most of the patients get access to that patient assistance programs. And I think about 1/3 of the population do benefit.
When you say 1/3 of population benefits, I suppose you mean 1/3 of population gets polatuzumab.
Yeah, of the DLBCL, they get. So rest 2/3, because of the cost, we are not able to benefit them.
Yeah.
Yeah.
But the bigger question is whether they benefit from the treatment.
Because I
or
don't.
who benefits from the treatment, I think is a question that
Yes.
that remains to be answered.
Exactly, sir. Sir, I have one question for you before the questions keep on coming. Regarding you mentioned about this APCOR plus RICE for the transplant eligible as well as for CAR T-cell eligible patients. Can we substitute, because APCOR is not available in our country? So can we substitute with Glofit, because Glofit is available on some accessible product list basically in our country. So Glofit plus RICE is better, or we must go for Glofit plus GMOX?
So, well, Glofit GMOX is a regimen which has been described for transplant ineligible patients, and there is Glofit RICE data as well in transplant eligible patients, and that looks very much similar to what I presented with epcoritamab. So, these are regimens which are not licensed or approved at the moment, so we can't use them at the moment. Unlike Glofit GMOX, which is a EMA licensed now, and it's going through licensing in the UK. So, it's ahead of the RICE combination regimens at the moment. But your question is very right. Glofitamab seems equally efficacious in combination with RICE, like as epcoritamab.
True, sir. In your present situations, based on your LDH remaining very high after the therapy and your PET is not in CR, do you change the therapy? Because you mentioned the data of LDH.
That's CAR T patients, yeah. So that's CAR T patients. We're talking of second-line CAR T patients.
Second-line
In fact,
CAR.
In fact, we showed similar data for third-line CAR-T previously. In some ways, this is applying the same to second-line CAR-T, and the message is consistent. If you have your pet at 1 month post CAR-T is predictable or is highly predictive. Now, we haven't applied ctDNA. I guess if we apply ctDNA to that analysis, we'll increase our positive predictive value even more. I mean, we have applied LDH and shown we can improve your positive predictive value, but we don't have ctDNA data on this patient population at the moment. But other groups have shown ctDNA value even at day 7, day 14, day 28 post CAR-T. So you can predict a group of patients who are at a high risk of progression based upon PET scan. If it is dual 5, then you probably would want to do something. The difficulty, Amit, is you don't know what to do for these patients. What would you do? I mean, strictly speaking, a bispecific antibody, if they have not had a bispecific antibody, could be an option, but it's only licensed for patients who progress. So you can't really use because they are going to progress, okay? Or you think they are going to progress. So that's not a treatment option which is available to those patients. In any case, bispecific antibodies don't do that well in patients who are progressing so early after CAR T cell therapy. Yeah. So it's just because we know that somebody is high risk doesn't mean we know what to do with that high risk, isn't it? And to know what you want to do with that high risk, you really need clinical trials. So in the UK, we have this trial where we are looking at a new CAR-T engager protein. It's called ELITA-001. It's a first in class, first in human CAR-T engager protein. It's CD20 binding and CD19 expressing kind of molecule. So what we are running a phase 1 trial with this now. It is available for patients who are in a PR at 1 month post CAR-T. So we give the ELITA protein infusion. It is aimed at enhancing antigen presentation to CAR T cells to re-stimulate the CAR T cells to see if we can, induce a deeper response. So it is an open question, and that's one strategy. There could be other strategies that people may want to try. We will hopefully present some data from the ELITA trial at ASH this year. But it's a phase 1 trial. We are essentially looking at safety and the dose for the phase 2 at the moment, and the timing of ELITA protein, because in theory we can give ELITA to everybody. In fact, we are going to start a new cohort where we are going to give the ELITA protein to all CAR-T patients to enhance CD19 antigen expression. So that's going to be our next cohort. But current cohort, we are giving it to patients who are in a PET positive PR.
Thank you, sir. And regarding you said about the dark zone signature and regarding the dose suggested R epoch versus we can go for POLA, RCHP, those patients who have got dark zone signature. Younger patient, fit patient, do you prefer if the patient has got dark zone signature, go for POLA, RCHP, or go for the dose suggested R epoch?
So to be perfectly honest, I don't know the answer on it. And I guess it depends upon who you talk to. There are believers in chemotherapy intensification, and there are non-believers in chemotherapy intensification. Going back a few years, I used to be a big fan of R-Codox and IVAC and IPOCAR and in believing in giving stronger chemotherapy to patients. But then, with time, you learn that it is probably you're selecting out patients, who are able to tolerate those chemo regimens. So I have kind of backed away from using the more intense chemo regimens, but I'm conscious that there are many other people who would give Dipocar or Arcodoxens to these double hit lymphomas. But the bigger question in my mind is FISH the right way of choosing to identify these patients, or is it the molecular signature? The dark zone signature was probably more prognostic from the slides I showed you. Patients who were positive on FISH but negative on dark zone signature, their outcome was not that different. Yeah. So maybe it's the molecular signature which is more relevant. There's also data using molecular signature. I don't know if you've seen in the UK, we did something called the Remodel B trial. It is going back a few years now. The trial was reported as a negative trial, by the way, that was adding bortezomib to R-CHOP chemotherapy. It was reported as a negative trial, but on a 5-year update, And retrospectively, we applied molecular signature because molecular high grade was not defined in the day 3 model B trial was done. But retrospectively, we were able to identify a group of patients recruited in the trial as having the so-called dark zone or molecular high grade signature. And they seem to benefit quite significantly from adding bortezomib to R-CHOP chemotherapy. Okay. But that has kind of remained where it is because there is no pathway to licensing for that regime.
No. And regarding you said about the C5 category of the patients who are the highest risk patients, and going doing MYD88 and CD79B, and if they are positive, it is must to offer them POLA.
So, I wouldn't put in such strong terms, Amit, but I would probably say that there are patients who are benefiting from POLA, from what we can make out. But the difficulty in real life is you don't have access to this information because you have no access to identifying your genetic clusters in diffuse large B-cell lymphoma outside of a clinical trial context, unless you start rolling out this as a genetic, test, whole genome sequencing for all your DLBCLs. So at the moment, it will remain confined. As far as I can say, it will remain confined largely to designing of clinical trials, and you will be looking at that subcategory in clinical trials, because it seems to have a prognostic relevance.
Thank you, sir. And my last question is about the CNS lymphoma, which was the best presentation, I may say, regarding the mediated trial. What was the purpose of giving first 2 cycles of R-CHOP first and then go for matrix? Is it to debulk the tumor first and then?
Yeah, I think it
it?
was one cycle, and it may even have been optional. I need to look at the myriad. It's mainly because some of these patients have a lot of systemic disease.
Okay.
When you look at secondary CNS lymphoma, there are variations within secondary CNS lymphoma, isn't it? Some patients have isolated CNS involvement only at relapse, and some patients have combined. And when you say combined, then there are different proportions. Some patients have a lot of systemic disease and very tiny amount of CNS disease. And it was felt at the time of designing the trial that you're not doing justice to those patients if you just give them matrix. So that was the purpose of squeezing in an R-CHOP into those patients at the very beginning to debulk the systemic tumor. And especially if it was a de novo kind of presentation, right? Where patient is R-CHOP naive.
Absolutely. Dr. Anshul Gupta, you have a question?
Yeah. So I just it was a great presentation. I would compliment that. And just one slide which you had shown in the EBMT data for the patients, DLBCL patients in remission. And you have compared the autologous stem cell transplant with CAR T cell therapy. And did there was any subset analysis done for the double hit lymphoma group who had achieved a CR, and in that particular group, was there any benefit of CAR T over autologous stem cell transplant? Because it was this was something I feel that by logic it goes like CAR T must be more effective than autologous stem cell transplant, because the Zuma 7 trial and other trials are now pushing the CAR T and as an upfront therapy for the lymphomas. So how do you take this data?
So that's a very nice question, Anshul. My difficulty with all this is the data that I see, that I'm aware of. I'm not convinced that CAR T is any better for double hit lymphoma as opposed to other lymphomas. In fact, your traditional prognostic markers, there were days previously when we used to say CAR T is agnostic of all kind of, CAR T is basically CD19 targeting. It is agnostic of all other kind of risk features. But the more we have seen, the more we have learned. In mantle cell lymphoma, TP53 mutation matters. If you're TP53 mutated, your outcomes with CAR T are inferior. Even though that did not come out of Zuma 2 trial, it did come out of the real world analysis from US and from our own group in the UK. Similarly, you will know we have seen other high risk features are quite relevant. If you enter into CAR T with bulky disease, high LDH, your outcomes are poor. So I'm not convinced that CAR T is going to be any better in the so-called double hit lymphomas, or yeah, that analysis. I'm not sure if it was done. It was certainly not presented. It was not part of that presentation uh, by the presenter. What did you ask something else about? Was there
Yeah,
another part to your question?
yeah, that was the point. My point, the subgroup analysis and the which you answered, that probably it was not done as a in the comparison.
Yeah. I don't think it was, and I'm not sure that if you do it, it's going to show anything different.
Mm. And is this ctDNA testing as a MRD marker, is it commercially available in UK presently?
So, there is no FDA approved ctDNA tool for DLBCL, at least that I'm aware of. The clonoSEQ assay, which is by Adaptive Immune Technologies, I think that is approved for leukemic phase diseases, CLL, and even mantle cell, but it's leukemic phase diseases. So it's not, for DLBCL kind of thing. So currently there is no uh, assay which is approved for use in this setting. And there are
Okay,
different assays which are being kind of promoted. Uh,
okay,
the assay that I described from the UK is a kind of academic lab-based assay, which is what the other one was. The Stanford assay originated in Stanford, the Asher Lizades group, which described that assay, which is now being commercialized.
okay. Thank you.
Thank you, Dr. Anshul. Sir, we have some couple of questions now come up from the audience. There's a question from Dr. Sujay. What is your take on CAR T versus autologous bone marrow transplant for those patients who have transformed from follicular lymphoma to DLBCL, if they are in CR after the first salvage therapy?
So I think the data that I showed is telling us that if a patient is in a CR after their salvage chemotherapy, then an autologous stem cell transplant is a very reasonable option to offer to these patients. A lot depends upon which treatment pathway your patient is already on. So if you have, for example, started your patient on chemotherapy, let us say this is second line chemotherapy, you started your patient on chemotherapy and your patient is responding to chemotherapy, you have assessed a response, if the patient is in complete response, you haven't initiated the CAR T pathway for that patient, then maybe you don't want to initiate CAR T pathway. Maybe you want to save all that money, just offer autologous stem cell transplant, and you can be confident that you're doing the right thing for this patient, in the sense, you're giving the patient an equally good chance of being cured, and maybe even a slightly better chance of being cured. I don't but think there is a huge difference between transformed follicular to DLBCL versus only DLBCL, or at least not. We don't have that kind of data, so I'll use the same strategy for that group of patients. You have a slightly different setting if your patient is already on a CAR T pathway. For example, you have already collected the T cells and you've initiated a CAR T manufacturing for the patient, and then you're giving chemotherapy whilst waiting for the CAR T manufacturing to happen. And if your patient has surprisingly gone into a CR with bridging therapy, then would you continue with CAR T therapy, or would you give an autologous stem cell transplant? So that is a question that sometimes comes. I don't change patients' pathways. If a patient is already on a CAR T pathway, you already manufactured CAR T, you already spent that money, and there is not much point. You would say that they have equally good outcomes and continue with their CAR T in that setting.
Perfect. Another question is from Dr. Shyam. Any experience with brentuximab plus lenalidomide plus rituximab plus acalabrutinib for refractory DLBCL? All four combined.
I'm not aware. If Dr. Sham is aware, then I'll be delighted to hear. I'm not aware of that combination, but they're all interesting, though. I think they're all combinations which have efficacy. They've been tested individually. Am I aware of acalabrutinib in relapse setting? I don't. I mean, upfront at least, it seems to be highly active. Acalabrutinib there are at least 2 trials I'm aware of just testing it in frontline setting.
The 3 triad is
Uh,
smart, I guess. Acala plus
Sorry.
the three drug, that is Acela plus rituximab plus Len. This is very
Yeah,
clear, smart study which took place for
yeah,
DLBCL. I think
yeah. That was
rituximab I am also not aware of.
that's frontline though. The
Yeah, for refractory DLBCL. Refractory DLBCL. Okay. Another question is from Dr. E. Montent. Which one do you prefer? High dose methotrexate versus intrathecal methotrexate for CNS prophylaxis?
So I only give high dose methotrexate now. I don't give intrathecal, with the exception of testicular DLBCL, where we give CNS prophylaxis with intrathecal once they're on R-CHOP chemotherapy. Otherwise, I don't bother with intrathecal methotrexate for most other DLBCLs. Whether you should give any whether you should give any CNS prophylaxis itself is a kind of question that one needs to answer. I have really reduced my use of CNS prophylaxis, I have to say. Uh, we Again, it's all retrospective data, but we have large scale retrospective data with over 1,000 patients analyzed, which shows very little benefit for any group of patients we have analyzed. So I have restricted CNS prophylaxis to very few patients now, maybe CNS IPI 5 and 6, and also, if you're trying to deliver your CNS prophylaxis at the end of R-CHOP, we have shown data that if you try to intercalate with R-CHOP, then it's not good because you end up with delays, treatment delays in the R-CHOP when you try to give methotrexate in between cycles. So we don't do that anymore. We give high dose systemic methotrexate after 6 R-CHOPs. But after 6 R-CHOPs, if you're already in a complete remission, then your risk of CNS progression is maybe 5%, 6%. That's it. So, and your risk of systemic relapse is probably much higher. If you're looking at high IPI patient, your risk of systemic relapse may be 40%, 50%. Your risk of CNS relapse is maybe 5%, 6%. And you're trying to give high dose methotrexate to reduce the risk of CNS progression, whereas you can't do anything about the risk of systemic progression. So I tend to focus on treating the systemic lymphoma.
Thank you, sir. Another question she has is, if you're bridging the patient with CAR T for an autologous stem cell transplant, what is the time interval between a CAR T and autologous stem cell transplant? Would you like to keep on the patient on if you're bridging with CAR T?
So we never bridge a patient to autograft with CAR T. CAR T is just too expensive to. So CAR T is delivered as a definitive treatment on its own. It's not delivered as a treatment to bridge. So only patients who will go on to have a transplant after CAR T are patients who have relapsed or are refractory to CAR T cell therapy. A small exception may be ALL setting, where sometimes you deliver a transplant as a consolidation to CAR T cell therapy in the context of some there is some practice. It's not my practice. I don't transplant patients after CAR T.
Thank you, sir. Another question is from Dr. Shilpa. She has a 44 years male in CR after giving RGDP, after having primary refractoriness to R-CHOP. So what would be line of therapy, whether auto or CAR T?
So again, the data we have seen from both the CIBMTR analysis and the EBMT analysis would suggest that it's very reasonable to offer an autologous stem cell transplant to that patient if the patient is in a complete metabolic remission after RGDP chemotherapy. So if you haven't initiated the CAR T pathway, then that's a very reasonable strategy to follow.
Thank you, sir. Another question from Dr. Shilpa. Most double hit lymphomas are GCB subtypes, according to data shared about clusters on molecular profiling. So which cluster did they fall into, and did Pola benefit in these patients?
Sorry, can you repeat that question, Amit?
So most double hit lymphomas are usually GCB subtype, according
Yeah.
to data shared about and according to data which is shared about the clusters on the molecular profiling. So
Yeah.
which cluster did this double hit lymphomas usually fit into? And did in this cluster Pola really benefited?
So I don't know the correct answer to that question because I don't think it's been analyzed that way. There was no benefit for GCB DLBCL within the Polaris trial, but there was benefit for the so-called dark zone signature, which is done with a different analysis, right? So it's not done with the genetic clustering is done with the gene expression profiling with a specific gene signature for the dark zone. And they seem to have some benefit. So it's slightly two different analysis. And I take the point that they will probably be a subset of the GCB type anyway, but they are identified by a slightly different technique as opposed to your gene or ABC GCB analysis.
Thank you. Another question is from Dr. Krishnanatham Kannan. If only MYC is rearranged, what would be line of treatment?
That's very interesting. I don't change my treatment for only MYC. Again, there is, if you look at retrospective data, there is retrospective data which will say that MYC rearranged DLBCL is maybe higher risk DLBCL, and there are practices of intensifying treatment for just MYC rearranged. But I'm not aware of any convincing data to change your treatment. I don't change my treatment practice.
Thank you, sir. Another very similar question from Dr. Sujay. If your patient of DLBCL attains remission with bispecifics, and then you post the patient with CAR T, and then after CAR, no, sorry, the question is, if the patient of DLBCL undertakes CAR T therapy, and after CAR T therapy, the patient relapses, and then you give bispecifics, patient attains remission, would you go for autologous stem cell transplant or allogeneic stem cell transplant or any other approach?
Again, a very interesting question. Some of you will know that we published the relapsed refractory DLBCL guideline, the BSH guideline, quite recently, actually. And this came for a lot of debate and discussion as to, the simple answer is there is no data for us to recommend anything, really. So in the guideline, for those of you who have looked at the guideline, we suggest that as an option, but we don't really go into any more detail because there is no data to support any statement I make. Do I consolidate? I don't tend to consolidate patients after bispecific antibody therapy at the moment. I deliver bispecific antibody therapy. It's either fixed duration or continuous therapy. If they're on epcoritamab, it's continuous therapy anyway, so they will just remain on epcoritamab if they're responding and benefiting. Glofitamab is fixed duration, and I just leave them and observe, and if they progress, then they will move on to the next line. So consolidation is something that I will consider for patients who have had chemotherapy reinduction, for example. So there are some patients that I will give polatuzumab, bendamustine, rituximab to after they relapse from CAR T cell therapy. So if they are transplant eligible, then I might consider transplant consolidation to these patients. Having said all this, Amit, I've looked after plenty of patients with CAR T and relapsing after CAR T. Unfortunately, as you know, more than 50% of patients that we deliver CAR T to will relapse, and will need further treatments. I'm trying to remember, maybe of all of this, there was only one patient that we ever got to a transplant. Yeah. So for all this talk that we do about transplant consolidation, majority of patients don't get there.
True, and that is a real world scenario.
Yeah, and it's really important for us to understand that at some point all this becomes theoretical. The real world is that these patients are not responding to further therapies. They are not getting into deep enough remission, forget consolidating that remission. Even if you look at published data, we haven't published this data yet, but if you look at published data from US, isn't it? That was a Zuma 7 follow-up. A very minority of patients ever made it to a transplant. So it is, our experience is exactly the same.
True, exactly, sir. Another question is from Dr. Yimon Tent. A patient with DLBCL coming with ptosis initially, what would be your line of management?
So I guess the difference is there a cranial nerve palsy here, isn't it? I mean, that is probably the implication of, and is this secondary CNS involvement or not? Yeah. And so I think that is critical though to begin with, isn't it? If it's just ptosis, and if your MRI brain is completely normal, you need to scratch your head a little bit and try and figure out whether there is CNS involvement or not. Because I've seen, for example, cavernous sinus thrombosis or cavernous sinus involvement. That's not CNS involvement, though. That's extra CNS. So I will not change my treatment on that basis. It is disease close to CNS as opposed to CNS There may be orbital involvement, for example, in some patients, which may cause this. So it all depends upon where your disease is. If there is true intradural disease or CSF positive disease or brain parenchymal disease, then I would treat it as secondary CNS lymphoma with Marietta regimen is our favored regimen. But if there is no convincing CNS disease, and ptosis by itself does not mean CNS disease. So if there is no convincing CNS disease, then I would treat it as standard DLBCL.
True, sir. Thank you so much. Another question is from Dr. Lee Ki Tat. 40 years female, CLL with Richter's transformation to DLBCL, proved on bone marrow biopsy, achieves CR after 6 cycles of R-CHOP. Do you now consolidate this patient with autologous stem cell transplant or allogenic stem cell transplant? 40 years female.
Right. Kind of slightly difficult one, isn't it? It depends upon prior treatment for CLL. It depends upon whether this Richter's is related to CLL or not related to CLL. Because we have seen Richter's transformations which are not kind of clonally related to CLL, and these patients do extremely well. R-CHOP is all that these patients need. They don't need anything else. But a majority are the same clone as your CLL clone. And in that kind of scenario, in a previously treated CLL, we would consider an allogenic stem cell transplant.
Perfect. Another question is from Dr. Babita Shodhi. You all showed all the slides were of adult patients. Are the scenarios same for pediatric patients also?
So the answer is I don't know. Unfortunately, the trials are the way they are designed, and most of the trials are designed for adult patients. So I can't honestly say that it's equally applicable to children.
True, sir. Well, I finished all the questions from the audience. Any other discussion want to ask any other question to Dr. Sridhar? Well, sir. So I think there are no hand raised signs. And we have taken lots of time of yours on this Sunday morning for you, very early morning for you. And thank you so much, sir, once again for a wonderful talk, fantastic talk, and a wonderful discussion. And it was a good learning from you, sir. Thank you so much.
Thank you, Amit and Anshul, and hope you enjoy the rest of your day.
Thank you,
Thank
sir.
you.
Thank you.